Hi, folks. Thanks so much for tuning in to the third session in our web conference series, Inclusive Advocacy, Addressing Ableism and Sexual Violence Response and Prevention. I'll be your host today. My name is Priscilla Clausen, and I'm a project coordinator at VALOR. I use she, her pronouns, and VALOR is California's Anti-Sexual Violence Coalition. By the end of our session today, you should all be able to complete a couple of the tasks on the learning objectives listed here. You should be able to define ableism, explain the basics of person-centered services, and describe the importance of promoting self-advocacy, consent, and access to education. To give us a foundation for our training today, we want to begin by discussing biases and disability bias. So if you're not familiar with the term or the concept of bias, it's basically a prejudice in favor of or against a person, a thing, or group and compared with another, usually in a way that's considered unfair. So as we talk about examining our biases, we also mean our overt actions and statements about a group. But in addition to that, we're talking about the judgments that we make immediately without further thought or examination. Implicit bias is the process of associating stereotypes or attitudes towards categories of people without our conscious awareness. That can also be referred to as unconscious bias. Disability bias is just what it sounds like, a bias or prejudice based on someone's disability. So bias can be categorizing or defining people based on their disability. So assuming all people with disabilities are the same, that they're all a monolith, buying into stereotypes about disability, having the perception that people with disabilities are inferior, that they have a lower status, that they are society's obligation or a burden. Doubting the credibility of people with disabilities. So making assumptions about whether or not they know what the truth is, or if they're telling the truth, or even assuming that people with disabilities are lying for attention. Having pity for someone with a disability. So feeling sorry for them or patronizing them. Fearing someone with a disability. So having like a personal discomfort with interacting with someone, or even being worried that you're going to say or do the wrong thing, or that associating with someone with disabilities may make people assume that you're also disabled and having a fear around that. So before we get too deep today, I want to acknowledge that we all have some level of disability bias. And this is something that's been deeply ingrained in our culture. We're all here to take a step toward combating that. And I want to acknowledge that we each have our own levels of knowledge and experience. And just because VALOR's leading this training doesn't necessarily mean that we know more than you. And we want to welcome your personal expertise as well. We want to respect that while everyone is working toward the goal of ending oppression, we can still see our own biases show up in some of these ways. And we don't want our fear of making mistakes to stop us from sharing. But we're going to use our mistakes as a chance to learn and to grow. Most of us here probably consider ourselves advocates for people with disabilities, right? It's part of our job. But when you're immersed in a culture that has negative stereotypes about disabled people, we often adopt many of these viewpoints without even realizing it. And even disabled people experience disability bias. I want to share some questions for us all to keep in mind because these biases really affect the services that we provide and the relationships that we're building with those that we work with. So keep these questions in mind, not only as you're going through this training today, but also as you go through your work on a day-to-day basis. Do you think of disabled as a negative word? Oftentimes people use the terms handy-capable or differently abled or even special needs for adults. And while this may be well-intended, it also reinforces the idea that disability is bad or wrong and that people with disabilities need special treatment rather than acknowledging that we're all unique and we all need customized options. When you think of a person with a disability, do you have sympathy or feel pity for them? Do you speak or interact with people with disabilities different than you do with people without disabilities? Something that I think a lot of us notice in our work is that people often speak to folks with disabilities the way that they would speak to children, or sometimes they speak to them very loudly, right? So those are just some things that we may notice in our work, or that we may even catch ourselves doing sometimes. Do you view disability as an abnormality or sickness, a challenge that needs to be overcome, corrected, or even eradicated? Do you think people with intellectual disabilities have a hard time understanding the truth? Do you view people with developmental disabilities as non-sexual beings, or that it's wrong if they express sexual desire? Do you think people with developmental disabilities should be able to have romantic or sexual relationships with non-disabled people? This is something that may come up in your work with service providers, right? There is oftentimes a power imbalance that will make relationships inappropriate for a service provider to be having a relationship with a client they're providing services for. But it's also important to interrogate whether or not that is what we're uncomfortable with and that is what is inappropriate, or if you think it's inappropriate that someone has a relationship with a person with a disability if they don't have a disability. Do you think that people with developmental disabilities should be able to have children if they choose? Our attitudes and beliefs can really impact how we support a survivor. So it's important for us to be aware of our own biases so we can provide appropriate support, but also so we don't cause further harm to survivors unintentionally. It's also important for us to be aware of our biases as they can get in the way of us providing person-centered and trauma-informed services. This image that you see on your screen is the intersectionality wheel of privilege. This wheel is a visual representation of how different identities are categorized in our society. Many of these identities change throughout your life, and you may notice that you're treated differently as those identities shift. The ring in the middle is the most powerful identity. Those are centered in our society and have the most privilege. This means that they can often be most effective allies because they're the ones that are really listened to and valued. Your job at the regional center is to be a strong ally for the folks that you support. This doesn't mean speaking for them, but rather using your position as a way to help them be heard. Erased identities are marginalized in unique ways, and you'll see these in between the power and marginalized rings. Folks with erased identities are often assumed to be rejecting their more marginalized identity, but are also being rejected by the powerful identities. They're excluded from both the influence of the inner circle and the solidarity of the more outcast circle. And the oppression in this ring is really more subtle. And the outermost marginalized identities experience more obvious discrimination than the other rings, and are typically represented in negative ways. Some of the ways that folks might consider minor, like being the subject of jokes in comedy, villains in media, using someone's identity, marginalized identity for costumes or school mascots, to more really life-threatening forms of oppression, like being targeted by criminal legal systems, eugenics, and violence. And I really just want you all to take a moment to identify your places within these rings, because not only can you use your positions of power to help amplify those marginalized voices, but you can use your other positions to help you really identify with the folks that you're providing services for. I also want to share a quote from Leah Lakshmi Haipshna Samarasinghe. Leah is a disability justice advocate and author, and this quote is from her book Beyond Survival. While I don't believe that we can separate ourselves from our privileges, we can leverage them towards justice. So as we talk about ableism and supporting survivors with developmental disabilities, it's also important for us to understand our own areas of privilege and how we can use our privilege, like I said, to support advocates and make sure that we are amplifying their voices and that their voices are being heard. So I want to take a few moments now that we have broken down some of these identities and talk about our own identities and experiences. Can you think of a time when your identity benefited you or protected you? Which of your identities is considered privileged or centered? I want to take about 10-15 minutes for you all to just do a journaling activity and just write down some notes and some thoughts about your experiences and some of the ways that you experience privilege or that your identities are centered and how those identities have protected you or benefited you. So let's take a few moments for that now. Okay, let's move on to ableism. Ableism is the discrimination or prejudice against people with disabilities. We can think of it as the outcome or the effects of disability bias. Just like other forms of oppression, you can be complicit in and benefit from it without actively meaning to harm others. Oppression that does not have obvious and negative direct effects on you personally can often go unnoticed. We live in a society where oppression is so immersive that many people benefit from it and don't really even know that it exists. That does not negate them from the harm that is caused. Ableism also contributes to the high rates of sexual violence that people with disabilities experience. Countering oppression, including ableism, should be sought out. This is a working definition of ableism from Talila Lewis. Talila is a social justice engineer, educator, organizer, attorney, and artist. It's considered a working definition because it recognizes that it is in flux. It's adaptable and aware that changes can and will need to be made to this definition. Ableism is a system of assigning value to people's bodies and minds based on societally constructed ideas of normalcy, productivity, desirability, intelligence, excellence, and fitness. These constructed ideas are deeply rooted in eugenics, anti-Blackness, misogyny, colonialism, imperialism, and capitalism. And just to highlight the photograph that you see on screen, it's featured from an organization called Disabled and Here, which is a disability-led stock image and interview series celebrating disabled Black, Indigenous, people of color. And they have created a series of free stock images for use and only ask that they be cited. We'll share this link with you in a link document as well. So let's work on another quick journaling activity. So just take maybe like 5 minutes and think about what are some of the ways that you have seen ableism show up in either your work or your personal life, or it can even be something that you did that you were corrected about or that you later realized was ableism. So yeah, just take a few moments to kind of jot some of those thoughts down, and then we will move on to discussing the different types of ableism. Okay, so ableism isn't just about people's beliefs and attitudes. It's also about the beliefs and attitudes that result in discrimination, segregation, social isolation, and unfair social and economic practices and policies. So that means that people with disabilities are not treated equal to people without disabilities, right? This limits opportunities for people with disabilities to fully become a part of our society. And when we talk about ableism, we know that it can show up in many ways. One of the ways that we see it show up is physically. We also see it show up personally and systematically. Physical ableism is how ableism shows up in physical spaces. So this is like when we see steps instead of ramps, not having automatic doors, not having accessible bathrooms, not having curb cuts, not having like varied seating options for different bodily needs and bodily accommodations, and having inaccessible materials. Personal ableism is really negative or harmful beliefs, attitudes, language, and behaviors. So personal ableism can be valuing people because of their disability being inspirational, right? Using those euphemisms or even functioning labels, right? People are still using the terms high functioning and low functioning, and that's a form of ableism. Using language that isn't preferred, right? So some people prefer person first language, some people prefer disability first language, and asserting your own opinions and your own beliefs on someone that is a disabled person, right? That's a form of ableism. So we always want to make sure that we're deferring to individuals. And then systemic ableism, this is really how policies, procedures, and laws contribute to inequity. So things like income thresholds, right? We know that it's really hard for folks with disabilities to have savings accounts, right? So if they want to save up to go on a vacation or buy a car, those things are really difficult for folks because it can impact whether or not they continue to receive benefits. Same thing with getting married, right? We know that is a really big concern to folks with disabilities, having their benefits cut off. Viewing and treating disabled people like society's obligation, like we talked about earlier, right? Only using them for inspirational purposes. Ableism also has a big impact on sexual health. So some of the ways that people with disabilities are commonly affected, they're often excluded from health class or other sexual education opportunities. If they are included in health classes, those curriculums are oftentimes inaccessible. They're not in plain language. They don't come in varied formats such as Braille or feature captions or alt text. So even if folks are included in those classes, oftentimes the materials aren't accessible to them or easy to understand. Sometimes inappropriate or what is considered inappropriate body parts, right, can be removed from a communication device or simply not added to someone's communication device, so that if they did need to talk about their sexual health, they physically don't have the language to do that. People with disabilities are labeled as having the mind of a child, right? It's very common for folks to say, that there's like a functional age for that individual, and that because they have what some folks consider to be the mind of a child, right? That they are incapable of having sexual feelings, wanting to have sex or wanting to be part of a romantic relationship. So they're not given any of that education. They're just assumed to be asexual. And then besides a lack of representation in sex education materials and a lack of accessibility in materials, there are rarely people with disabilities who are employed as sex education teachers. So we don't see that representation there. And then people with disabilities are also excluded from positions of power that make policies and materials surrounding sexual health. So it's really kind of an all-encompassing on every level that folks are excluded. And then when we talk about impacting sexual health, we also want to talk about ableism in the anti-sexual violence movement, because this can also impact the way that someone moves forward after experiencing sexual violence. So you may encounter some of these examples in your work with survivors with developmental disabilities, or as you begin to work more closely with local rape crisis centers. And it's important to be able to identify these so that you can help combat them and improve the services that survivors with disabilities are experiencing. One of the ways that we've seen ableism shown up is inaccessible exams. So I've personally been to hospital calls where exam tables don't have guardrails on the side. So if someone has like cerebral palsy, right, and they have a spasm or something, they don't have those guardrails on the side that will physically keep them on the table and keep them safe. Even though a lot of them are in hospitals, they don't have Hoyer lifts in the room. So even being able to get someone onto a table can be really difficult. There's a lack of education about sexual health and healthy relationships within rape crisis centers and the movement. Organizations are uneducated about disability and trauma and how it affects folks with disabilities. There are harmful biases that we show up. Folks don't understand the intersectionality of disability with other identities. Not understanding the unique needs of folks when safety planning. So if someone goes to a rape crisis center or a domestic violence shelter and they need a safety plan, they may not be considering all the unique aspects of someone with a disability, such as their physical access, whether or not they have a service animal or a care attendant. So they don't know how to make those safety plans that will really assist someone when trying to get out of a harmful situation, and that are really pertinent to that person's everyday life and that they need in order to keep them safe. And then listening to neurotypical or able-bodied appearing support people rather than disabled survivors, right? This is something we see across the board. Folks talking to a support person or someone accompanying the person with a disability rather than speaking directly to them. So let's shift focus now and talk a little bit about person-centered services and person-centered thinking. These next two slides come directly from one of our statewide conference sessions titled Supporting Survivors with Developmental Disabilities Through Person-Centered Practices. We had Stephen and 3 other certified trainers for person-centered practices present at our statewide conference, and they presented some tools that they use in planning supports and services for regional center clients. So you can reach out to Stephen Browning if you want more information about the tools that they adapted for use with survivors. But person-centered thinking is an intentional approach to developing positive relationships. Many times services and plans are created based on what others think is important for someone rather than what is important to someone. Purposefully moving away from this model of services, person-centered thinking supports people to have positive controls over the life that they desire while incorporating health and safety concerns that they and their circle of support would like to incorporate as well. Person-centered thinking keeps the person and those who care most at the center of the decision-making in order to validate and really hear the person, even if we don't always agree. Person-centered thinking understands and encourages a continuous learning process and incorporates practices that help us support rather than fix, build the culture of learning, partnership, and accountability, affirm our belief that everyone can learn, work for humans because everyone is different and the supports that they need must be based on who they are. Supported decision-making is something that helps people hear the opinions and advice of those supporting them without losing the autonomy of making decisions independently. Supporters are family, friends, advocates, professionals, and support staff that the individual trusts to help them make choices. And they're frequently referred to as supported decision-making team or supporters. Supporters help the individual get and understand information that's relevant to the decisions, as well as understand options, responsibilities, and consequences of decisions. Supporters must weigh the information and make an informed decision. Supporters also help the individual communicate their decision to others. Supported decision-making is usually done as a team so that there are plenty of perspectives and to protect the individual against abuse and manipulation by one individuals or smaller groups of people. Supporters don't have to agree with the decision that the person has made. Just like if you ask your friends or your family members for advice, you don't have to take it. Supported decision-making gives people the tools to make informed choices and empowers them to live fuller, safer lives that are self-directed. I'm now going to share a video. So hold on one moment while I get that loaded. Okay, so this video features Max Barrows of Green Mountain Self Advocates discussing and explaining what dignity of risk is, and we'll go over it after the video as well.
One thing that is really big in self-advocacy and the work that I do, and we discuss it a lot, is the dignity of risk. The dignity of risk is the opportunity and the right to make mistakes. It's one thing to be told things through lecture, but how else can you learn if you don't make mistakes? Life is about learning from the mistakes you make. I appreciate, and we appreciate, protection from people, but please don't protect us too much or at all from living our lives. We are going to have to encounter failures through decisions that we make. But the way to conquer that is to get up on your feet, brush yourself off, and learn from that, because people grow by encountering failures and making mistakes in their life. It's really the #1 way of learning, of where lines are drawn, and also it helps with learning about yourself. The dignity at risk is one of many opportunities that people with disabilities deserve to have. It's one thing just to give them like only a select few, but clearly, even saying in the Americans with Disabilities Act, people with disabilities deserve to live their lives with no limits of opportunity. It really opens the doors for people with disabilities to really discover what is out there and to take advantage of what is out there and not be limited to only certain things due to the overprotection that people with disabilities unfortunately have to live with.
Okay, let me change my screen share one moment. Bear with me. I'm doing all my own tech. Okay. There we go. Okay. So I really love that video. I love Max. He is a great educator, and the Green Mountain Self Advocates, if you're not familiar with them, definitely look them up. They share a lot of really great information. And yeah, I just love a lot of their trainings, and Max is a great educator. So like Max said, dignity of risk is really about acknowledging that life comes with different degrees of risks, and that people who care about you may not always agree with the choices that you make, but it's still your right to make your own choices and your own decisions. And this is particularly true when we're talking about sexuality. Disabled people are often assumed to be non-sexual, right? Like we talked about before, and like I'm sure a lot of you are aware of, right? When folks with disabilities display interest in sexuality, it's oftentimes shunned or silenced. And this can lead to people hiding choices rather than risking being admonished or even punished by the folks in their support circles. In your own life, you probably have an understanding that not all the risks that you take are negative or will have negative outcomes. But this understanding really needs to be practiced when providing supports for folks with disabilities. We need to respect the rights of those individuals to take reasonable risks. We can assist with providing more information or options when they're making choices, but if that person is not in any like immediate danger, they really have the right to explore things, and that includes exploring their sexuality. Um, we can always work on balancing someone's autonomy with our urge to protect, and that's something that we really need to be working on when it comes to sexuality. Um, if people are constantly making decisions on your behalf, that that can really impact a person's decision making skills and abilities. It can cause people to rely on others to tell them what's right. And that can put people in a really vulnerable place, right? If you're not sure who to trust or you're not sure to trust yourself, then you're always going to look to folks. And if someone is looking to prey on you or harm you and you trust them above yourself, then right, that puts you in a really vulnerable position. So we really need to work on resisting our own urge to protect people and promote their abilities to, you know, take risks and make choices for themselves. So self-advocacy and sexual health. As service providers, you want to be positive and supportive in all areas of a person's life. When you're thinking about the people that you support, I think that you can probably agree that sex and sexuality has been an area that's not been given the same importance or emphasis as other areas of their life. Oftentimes, sex and sexuality is ignored or thought of negatively. So regardless of what our own personal views on sex and sexuality are, every human should have the right to make their own choices about their own bodies. So for people with disabilities, oftentimes their bodies are not considered to be private, respected spaces. And because of this lack of respect, people with disabilities receive a lot of negative messages about sex. So messages that they're not sexual beings, that they don't have the ability to decide if they want to have sex, that they don't deserve the rights and responsibilities that other adults get, that they're innocent or childlike and they need to be protected from sex, that they can't be trusted to make the right choices, that they can't be part of the LGBTQ plus community because they aren't capable of knowing their own sexual orientation or gender identity, that no one would ever be interested in them romantically or sexually, or that they are to blame for any abuse that they receive. Some of the impacts of these negative messages are people being worried and fearful, people being lonely and having increased isolation, shame, right? Especially regarding their body or anything sexual. They may stop reaching out for support or even start practicing unsafe or risky sex. There's an increased risk of abuse. And many people feel that reports of abuse will not be taken seriously. We see that among all survivors, but specifically survivors with disabilities. Many of the survivors that we have interviewed in focus groups have shared that they didn't report their abuse because they didn't think anyone would believe them. So one of the most important things that you can do to help a survivor is to listen to them and believe them. We can also begin combating sexual abuse by giving positive and supportive messages about sexuality and healthy relationships. This will not only help people with developmental disabilities to protect themselves against abuse, but it will let them know that it's okay to talk about abuse that has occurred and that you're someone that they can go to for help. So like we mentioned in the ableism section, people with developmental disabilities need to be included not only in learning about sexual health and healthy relationships, but also included in teaching it and creating materials and policies around the implementation of sexual health for disabled individuals. So give people with disabilities the information they need to make safe and healthy choices regarding sex and information and sex and relationships. Teach them warning signs of abuse and how to reach out for help if something happens and they are abused. Use accurate language about body parts and sex. Personal care routines might be the only time that people with developmental disabilities are given language about their bodies. Teaching the difference between care tasks and sexual intimacy can help folks determine when boundaries are being crossed. So make sure communication devices include language for body parts and relationships so that they have that language. Give information about family planning, including birth control options and prevention of sexually transmitted infections. Consent isn't something that's always integrated fully into service settings. Oftentimes conversations about consent aren't happening, especially when individuals have higher support needs when it comes to like personal care tasks. This is something that should be taught to everyone at all ages, right? Everyone has the right to bodily autonomy and making informed decisions about their body and life. This applies to sex and relationships as well. Information that is given should be done so in ways that are inclusive and takes into account different cultures, genders, sexual orientations, and abilities. Don't assume that because individuals are adults that they've already been taught all of this information. We want to give refresher courses and updated courses and materials. Many adults were not taught about the basic aspects of sexual health, and also have not been included in more nuanced conversations about various sexual orientations, new methods of finding dates, or intricacies of consent. So why is it important to promote healthy sexuality and relationships? It really normalizes the fact that all people are sexual beings or can be sexual beings, not just non-disabled, heterosexual young people. When something is normalized, it makes it easier for most people to talk about when something good or something bad happens. Or even when you're not sure how you feel about something, it can make it easier to talk about that situation so that you can kind of decide how you feel about it. It gives an opportunity to show sexuality in a positive light, not just abusive. Many people with disabilities are used to others assuming they cannot consent or aren't capable of having a fulfilling relationship, and that any relationship must be abusive. So showing people that they are seen as valued can help them reinforce their own feelings of being valuable. And that can help them recognize when treatment actually is bad or abusive. It can help to identify healthy and positive relationships. Healthy sexual and dating relationships can foster community integration. It can reduce sexual abuse, stress of unplanned or unwanted pregnancies, and sexually transmitted infections. We'll share a few resources for teaching sexual health advocacy. And these are good resources for incorporating education on healthy relationships and sexual violence. Sex Ed for Self-Advocates is a free guide that was written specifically for people with autism, ages 15 and up. It includes information about healthy relationships and dating. LGBTQ folks and self-advocates are really the experts in their own life. So the Rainbow Support Guide Group is a guidebook that helps family, friends, and service providers learn how to better support LGBTQ plus folks with developmental disabilities. And then peer-to-peer Bridging the Gap Through Self-Advocacy was designed to provide self-advocates with tools and information to support peers who are survivors of sexual or domestic or intimate partner violence. It's a self-paced class that was written in plain language with video and audio components. I will provide a copy of links to these resources as well. And then just a reminder to please join us for part 4 of these sessions. Part 1 and part 2 recordings are already available, but make sure you register for part 4. It takes all of us, recognizing and preventing sexual assault. Thank you again for joining us. Please feel free to reach out if you have questions or concerns, and feel free to look VALOR up on social media. Thank you again so much for joining us today, and we hope to see you in session 4.